Medicare just released 2026 cost increases, and the headline is hard to ignore. While Social Security cost of living adjustment is up 2.8%, the standard Medicare Part B premium surges 9.7%, the biggest jump in years. If you are relying on a fixed income, that gap hits your wallet fast, and that is only the beginning. What is really driving these higher costs? Who actually pays for what? And are there ways to navigate the shifting rules this year? Let's break it all down, starting with how hospital coverage exposes some hidden risks, even for the 99% who think their premiums are free. Most people enrolled in Medicare never see a bill for Part A hospital coverage. That is because nearly everyone qualifies for premium-free Part A by working at least 40 quarters, essentially 10 years, at jobs where they paid Medicare taxes. It does not have to be all at once, and it does not even have to be your own work record. If your spouse worked those 40 quarters and is at least 62 years old, you can use their record to qualify for premium-free hospital coverage too. This rule covers about 99% of Americans on Medicare. And for 2026, nothing about that qualification has changed. But there is a small group, about 1%, who do not meet that 40-quarter mark. For them, the monthly cost of Part A is real and rising. If you have between 30 and 39 quarters of work credits, the 2026 premium is $311 a month, which is up $26 from last year. If you have fewer than 30 quarters, the monthly premium jumps to $565 a month. That is a $47 increase over 2025. These numbers can be a shock, especially for people who spent years outside the United States workforce, recent immigrants, or those who did not pay into Social Security and Medicare through their jobs. A lot of people wonder why there is any premium at all, especially after paying Medicare taxes for decades. The answer is that those payroll taxes only fund Part A hospital benefits, and even then, they do not stretch far enough to cover all the costs nationally. That is why the system uses a work credit rule to decide who gets premium-free coverage and who does not. For married couples, the spousal work record option can be a key safety net, especially if one spouse stayed home or worked part-time. Once you are in, either through your own record or your spouse's record, you remain enrolled in premium-free Part A as long as you stay enrolled. This is the starting point for understanding Medicare costs. Most people pay nothing for hospital coverage, but for the small group who do, the price is steep. Now, once you are enrolled, the next layer is not about monthly premiums. It is about what you pay when you actually use hospital services. That is where the deductible and other cost sharing come in, and those numbers work very differently from what most people expect. Hospital costs under Medicare do not follow the annual deductible model most people expect. Instead, Part A uses a benefit period. Every time you are admitted to the hospital, a new benefit period can start, and with it, a new deductible. For 2026, that deductible is $1,736, up $60 from last year. That deductible covers your first 60 days of inpatient care, and it resets if you have been out of the hospital for at least 60 days. So, if you are hospitalized twice in a year with enough time between stays, you could pay that $1,736 more than once. If your hospital stay runs longer than 60 days, out-of-pocket costs rise sharply. From day 61 through day 90, you will pay $434 per day, a $15 daily increase over last year. If you need even more time, Medicare gives you up to 60 lifetime reserve days. These are one-time use days you can draw from over your lifetime, but each reserve day has an $868 daily copay in 2026, up $30 from last year. Once those reserve days are used up, you are responsible for the full cost. Skilled nursing facilities follow their own cost-sharing schedule. The first 20 days are fully covered by Medicare. Starting on day 21, you will pay $217 per day, a $7.50 increase for 2026. After day 100 in a skilled nursing facility, Medicare coverage ends and you are responsible for the entire bill. These numbers add up fast, especially for people without any supplemental coverage. Unlike Medicare Advantage or Medigap plans, traditional Medicare leaves you exposed to these benefit period charges. That is one of the main reasons many people choose extra coverage, to avoid the risk of paying multiple deductibles or high daily copays if they end up needing extended care. For anyone sticking with traditional Medicare alone, understanding the benefit period model is essential, because these charges do not just happen once a year. They can hit any time you're admitted, and sometimes more than once. Knowing this helps you decide whether a supplemental plan or an Advantage plan better protects you from unpredictable hospital bills. A closer look at the numbers reveals just how much ground people are losing, even before considering anything beyond the basic premium. The standard Part B premium for 2026 climbs to $202.90 a month, up from $185 last year. That is a $17.90 monthly increase, which adds up to $214.80 a year that needs to come out of household budgets. For many, this is the largest jump in recent memory. Meanwhile, Social Security's cost of living adjustment for 2026 is 2.8%. In dollar terms, the average Social Security recipient will see about $50 more per month in their check. But with $17.90 of that eaten up by the Part B premium alone, only about $32 remain from the raise before any other rising costs are factored in. That is the reality for someone on a fixed income. The gap between these two numbers is not just an inconvenience, it is a real squeeze on day-to-day life. The Part B premium is rising 9.7%, which is more than 3 times the rate of the Social Security increase. Healthcare costs are taking a bigger slice of the monthly check, leaving less for groceries, utilities, and everything else. What makes the situation even tougher is the way Social Security calculates its annual adjustment. The formula, called the Consumer Price Index for urban wage earners and clerical workers, tracks the price of items like food, housing, transportation, and clothing. It does not directly account for healthcare costs, even though medical expenses are one of the biggest worries for retirees. So while the price of bread or gas may rise or fall, the cost of staying healthy keeps rising at its own pace, often much faster than the rest. For an average beneficiary, the numbers are clear. Suppose you are getting $1,800 a month from Social Security. The $50 COLA bump sounds helpful, but after subtracting the $17.90 increase for Part B, you are left with just over $32, barely enough to cover a single trip to the grocery store. And this does not include the deductible, which is also up by $26 this year, or the rising costs of supplement plans and prescription coverage. This pattern has been repeating for years. Healthcare expenses tied to Medicare keep rising faster than the income meant to help cover them. For many, that means making hard choices, cutting back on basics, skipping other bills, or dipping into savings to bridge the gap. The numbers are not abstract. They show up in bank accounts and monthly budgets, forcing people to stretch every dollar further. The math is even starker over time. If premiums keep rising at nearly 10% a year, while Social Security only grows by 2 or 3%, the gap will widen quickly. Within a decade, the Part B premium alone could double, swallowing up most or all of any future cost of living increases. For those on fixed incomes, this is a long-term security issue and a real threat to maintaining basic health care. In short, the income squeeze from rising Part B premiums versus modest Social Security increases is real, and it affects budget decisions for millions. Understanding this squeeze is the reason plan choices matter so much. Next, we will walk through how Parts C and D are changing and what that means for the options people have to protect their budgets and their health. Crossing into higher Medicare premium brackets can happen faster than most people realize, and it is not always because of a big raise. For 2026, the threshold for the income-related monthly adjustment amount, called IRMAA, starts at $109,000 in modified adjusted gross income for single filers and $218,000 for married couples filing jointly. These numbers are based on your 2024 tax return, not your current income. That 2-year look-back catches a lot of people off guard after one-time events like selling a house, converting a retirement account, or cashing in investments. Even a large required minimum distribution or a lump sum pension payout can push you over the line for 2 full years of higher premiums. About 8% of people on Medicare Part B are now paying IRMAA surcharges. In 2026, if your income is just $1 over the threshold, your Part B premium jumps from $202.90 per month to $284.10 per month. That is an extra $81.20 every month, or $974.40 a year for a single dollar over the line. For couples, the math is even more dramatic. Crossing the $218,000 threshold means both spouses pay the higher premium, doubling the household impact. The next IRMAA tier starts at $137,000 for singles and $274,000 for couples, with surcharges increasing sharply at each level. The highest bracket for those with $500,000 or more in income, $750,000 for couples, pays $689.90 per month per person for Part B alone. What makes this year's squeeze even tighter is that the IRMAA thresholds only rose about 2.4% to 3%, while the base Part B premium jumped 9.7%. This mismatch means more people are getting pulled into IRMAA territory, even if their income only went up a little or stayed flat, but the brackets did not keep up with inflation. It is especially tough for people who had a one-time income spike 2 years ago, but are back to a lower income now. Unless you have had a qualifying life-changing event like retirement, job loss, or the death of a spouse, there is no easy way to appeal. The Social Security Administration does allow you to file Form SSA 44 to request a reduction if your income dropped due to a major life change, but not for investment sales or voluntary withdrawals. On top of all this, the Part B annual deductible is up to $283 for 2026, a $26 increase from last year. Unlike Part A, this deductible is annual, not per benefit period. If you have a Medicare supplement plan, except for the older Plan F or Plan J, you will pay this deductible out of pocket before your supplemental coverage kicks in, with supplement premiums themselves up an average of 14% this year. The total out-of-pocket exposure keeps rising. For those on fixed incomes, these increases stack up quickly, and every new dollar in income can have outsized consequences for what you pay for your health care. The bottom line is that bracket creep, the 2-year look-back, and the rising deductible all combine to make Medicare planning more complicated and more expensive than ever. It is not just about the headline premium, it is about understanding how every piece fits together, especially if your income hovers near the IRMAA thresholds, or if you are managing withdrawals and sales in retirement. Even a small misstep can mean hundreds or thousands more in annual costs with very little warning. Plan carefully. check your 2-year tax picture before large withdrawals or sales, and consult a trusted advisor if you are near a threshold. That is the Part B income squeeze in a nutshell. Medicare Advantage plans are often advertised as having $0 premiums, and for most people, that is true. About 76% of Advantage enrollees pay nothing each month for their plan, but the story changes quickly when you look at where you live. The national average premium for those who do pay actually dropped 4% for 2026, but that number hides some wild swings at the state level. In Wyoming, the average premium more than doubled, shooting up 120%. Meanwhile, Arkansas saw the opposite, a 68% drop in average premiums. These are not small differences. A beneficiary moving from one zip code to another could see their monthly cost change overnight, just based on geography. That premium volatility means the $0 promise does not always hold true, and it is not just about the headline number. The underlying risk for beneficiaries is that plan costs can change dramatically from year to year and from place to place, making it hard to predict what you will actually pay if you travel or relocate. For anyone comparing plans, it is not enough to look at the national average or the marketing slogans. The real story is written in the fine print, and it depends a lot on your address. Out-of-pocket costs are where the real risk sits for anyone on a Medicare Advantage plan. For 2026, the average maximum out-of-pocket limit is jumping to $5,900, a sharp $900 increase from last year and an 18% rise. This number matters most if you face a serious illness or a string of hospital visits. It is not just a theoretical ceiling, it is the real-world cap on what you could pay before your plan covers everything else. But that is just the average. Some plans set their limits much lower, while others climb much higher, depending on where you live and which plan you choose. The federal government sets the absolute maximums, $9,250 for in-network care, and $13,900 if you use both in and out of network providers. Most people never hit these upper limits, but knowing they exist is important, especially if you have chronic health conditions or expensive treatments. That average $5,900 out-of-pocket maximum is a reminder that even with a $0 premium, the real exposure comes if you actually need care. With costs rising this fast, the safety net feels a little thinner every year. Bottom line, when you compare Medicare Advantage plans, look beyond the premium and focus on out-of-pocket limits and how they match your health risks and local options. Keep this risk in mind as we move on to the next section, where we compare these trade-offs to supplement plans and standalone drug coverage. Official numbers from the Centers for Medicare and Medicaid Services, CMS, say the average Part D prescription drug plan premium will be $34.50 a month for 2026. That sounds like good news, but it does not match what most people are actually paying. In reality, the enrollment weighted average last year was closer to $55 a month, much higher than the headline figure. Some plans still advertise $0 premiums, while others have climbed as high as $172 per month. That is a huge range, and it means the average does not tell the real story for most enrollees. For those affected by the Income-Related Monthly Adjustment Amount, IRMAA, the gap gets even wider. A married couple, both on Medicare and both in an IRMAA bracket, could see their total monthly drug premium hit $72 each, or $144 together, even if their plan advertises a much lower base rate. The reality is that many people are opening their bills and seeing numbers that do not line up with what they were told to expect. This disconnect between official averages and actual costs makes it hard to trust the headlines, and it leaves many wondering what is really driving their out-of-pocket expenses. prescription drug costs are where the real sticker shock hits for many people, especially those who rely on medication every month. For 2026, the deductible for a standalone Part D drug plan climbs to $615. That is a $25 increase from last year, and it is now the cap for most plans. So if you have a standalone drug plan, you will likely see that number on your bill before coverage kicks in. But the real upheaval is happening in Medicare Advantage drug coverage. Just a year ago, the average drug deductible in Advantage plans was $39. Now it is projected to jump all the way up to around $420. That is not a typo. It is more than 10 times higher in what you pay out of pocket before your plan starts covering prescriptions. The odds of finding a $0 drug deductible in an Advantage plan are shrinking fast. In 2024, about 60% of Advantage enrollees paid nothing up front for their drugs. By 2025, that dropped to 31%. And for 2026, if everyone stayed on their current plan, only about 14% would keep a $0 deductible. This is the direct result of insurance companies absorbing more of the costs under new federal rules, and then pushing those expenses back onto beneficiaries through higher deductibles. It does not end there. The out-of-pocket cap for Part D drug costs is also rising, from $2,000 in 2025 to $2,100 in 2026. For anyone managing chronic conditions or expensive prescriptions, these changes mean more money out of pocket before any real help kicks in. The bottom line is simple. The cost of staying on your medications is no longer just about monthly premiums. Deductibles and caps are now a central part of the equation, and for many people, they are the part that hurts the most. Take a close look at your plan now and compare options, because these deductible shifts can change what you pay first and most. Medicare's rising costs now outpace the average retiree's income growth, forcing tough choices for millions navigating fixed budgets. This is not just about numbers, it is about access and dignity and the future of aging in America. At current rates, healthcare costs double every 8 years. The question is not if change is coming, but how soon we will demand it. Share your perspective below. Your voice matters. Thank you for listening, and I will see you in the next video.